Hello there, welcome to another episode of 10 Clinical Minutes. This time, glad to have you back. We're talking about atrial fibrillation with an asterisk for non-cardiologists. This should help you out in your primary medicine wards, primary medicine clinics, and also in the hospital. So we start out with a differential diagnosis. We're going to have a couple different buckets and categories for these. One of these are cardiac structural defects that causes changes in arrhythmia. Another is cardiac function defects that causes changes in how the heart operates. These are going to be more systemic causes. Of note here, stimulants can include cocaine, methamphetamines, as well as common stimulants such as caffeine, of which I have maybe 4 or 5 cups today. Then you have in the middle pulmonary pathology, which can either cause changes in cardiac structure based on pulmonary hypertension, which is reflected in the cor pulmonale, common cause or common side effect in COPD, or through the relative hypoxia, which would be a more systemic effect, therefore affecting the cardiac function. Lastly, we have 2 more categories. We have idiopathic and iatrogenic. Idiopathic is the most frustrating of these and the one that we just don't know why it happened. Then iatrogenic can be due to things that we did to a person. And that can be a myriad of factors, either through causing electrode abnormalities, through damaging the heart with the procedure, giving the person inappropriate medication. There can be many causes of an iatrogenic atrial fibrillation. A little bit of background for you. In the Framingham study, famous cardiology study, 37% of patients developed A-fib after 55 years of age. It is the most common heart arrhythmia in the general population. 80% of those didn't have a precipitant, which is kind of discouraging, but 20% of those did. And sometimes if you treat those precipitants, you can resolve the AFib and abort it. It increases the risk of stroke, heart failure, dementia, and death, which is why we care about it. The dementia is related to either relative hypoxia from lack of blood flow or from embolization, which is a major complication of AFib. Those embolizations can also go elsewhere in the body, such as the mesenteric arteries or distal extremities, causing acute arterial occlusion. The risk factors I like to think about is the American plague plus. So you have hypertension, hyperlipidemia, diabetes mellitus, obesity, and then its affiliate, sleep apnea, all of which we see in an increasing number of patients and commonly together, largely related to energy imbalance. That is a topic for a whole nother day. Then excessive alcohol use can also cause it, and the reduction of alcohol can ameliorate symptoms. And then COPD is also well classified as an independent risk factor. So some functional definitions. A-fib is an irregular rhythm without P waves. A-fib without RVR is when the heart rate's less than 90. With RVR, heart rate greater than 90. You may see some differences amongst institutions or providers if they call it 90 or 100 or 110. Some of that's due to symptomatic control. If somebody is asymptomatic but less than 110, somebody might not classify it as RVR, and they might not treat it as RVR. If somebody's greater than 110, almost always it will be treated. But if somebody's symptomatic and it's 95, you might still call it RVR, even though other practitioners might not consider it as such. Rate-controlled AFib is when the heart rate is less than 90 with an intervention, such as a beta blocker, calcium channel blocker. And then breakthrough is when you have RVR despite interventions. So AFib kind of produces a mysterious patient. You have asymptomatic AFib, which is a person who does not have any symptoms and can be relatively a frustrating etiology. Now, this person may actually have symptoms, but they might be compensated. This could be your older patient who comes in saying, I used to take the stairs, but I don't take the stairs anymore. Or it could be symptomatic, ranging in severity from just simple fatigue and exercise intolerance all the way down to syncope, angina, and pulmonary failure. Why does a person develop symptoms? There's a broad spectrum. Some of it could be embolization, could develop the symptoms. But when it's related to blood flow, the atria are contracting, the heart is pumping, but it's ineffectual contractions. And so the ineffectual atrial activity reduces the end diastolic volume because there's decreased filling of the ventricles during diastole. Now, if you decrease the end diastolic volume, you're inevitably going to decrease the stroke volume because your total capacity to force out of the heart during systole is going to be decreased. And if you decrease the stroke volume, you're going to decrease the cardiac output. And with decreased cardiac output, your systemic pressures decline, tissues become hypoxic, and you begin to develop symptoms that are related to that relative loss of blood flow, also known as hypoxia. So there's several different types. These definitions are pulled from a recent New England Journal of Medicine article that was just published this year in 2021. Paroxysmal, persistent, and long-standing persistent. They're a little bit on a spectrum, but you don't have to necessarily move through each of these steps. You can be diagnosed with persistent A-fib based on symptoms greater than 7 days, and you've been in A-fib the whole time. And so in paroxysmal, key points less than 7, you can be in sinus rhythm, pretty common. You often might have to have a Holter monitor in order to diagnose it. With persistent, you're going to catch it in the clinic or in the hospital on EKG. Sinus rhythm is rare. You need to cardiovert. With long-standing persistent, you're unable to get them out of AFib and into sinus rhythm despite cardioversion. And in part, that's because there's been so much atrial fibrosis and remodeling that there's not really an ectopic trigger point that's needed. The entire heart begins to stimulate itself to be an AFib, and it's a condition that you will very unlikely be able to get them out, and instead have to tolerate the AFib and try and enforce rate control and appropriate oxygenation of tissues, as well as cover for embolization. So this is a standard pathway treatment. Historically, you start out with rate control, then you do rhythm control, then you do cardioversion in order to get the person back into sinus rhythm. That can be either electric or pharmacologic. And then if that doesn't work, you can do ablation, where you forcefully cardiovert the patient. Traditionally, primary care has stayed here in the rate control area. Cardiology has handled everything else. Unfortunately, an ablation or cardioversion can need to go back and have to require rate control or rhythm control at a later point in time. And that's because the patient who is cardioverted may very well revert back into atrial fibrillation. And the patient who's ablated may also revert back into atrial fibrillation, at which point they need to return to the pathway and then do rate control and rhythm control in order to prevent symptoms. Recent studies published in October of last year seem to indicate that there might be some rationale for moving the standard of care out of just rate control first into rate control and rhythm control, with decreased adverse outcomes and a decreased persistence of AFib in the population who had rhythm control versus standard of care, which is rate control. This could cause you to think that primary care should begin to move into rhythm control, and there could be some agents that a primary care provider could begin to safely offer with the proper training. And that would leave cardiology then here still in a consultant service for the rhythm control, and then also still handling the cardioversion and the ablation. So how do we treat it? Lots of words on this slide. You can pause it. Primary care, still we're going to emphasize rate control with beta blockers or calcium channel blockers. I bolded the ones that you'll see most commonly used. Cardiology is going to do rate, rhythm, and then interventional treatments, which is the cardioversion that we discussed, catheter ablation with either freezing or radiofrequency, or possibly the coolest one, cardiac maze using sutures to ablate the heart. We get to the point where a person comes in with atrial fibrillation and you ask yourself, should I cardiovert? The answer is almost always going to be yes, especially if they're symptomatic. First thing you got to assess, are they hemodynamically stable or not? If they're hemodynamically unstable, hypotensive, can't perfuse organs, showing signs of end organ failure, then you would administer immediate cardioversion with synchronized shock and possibly give them some fluids. If they're stable, we have a little bit more time. So then you go after the heart rate with some of the agents that we discussed earlier, the beta blockers and the calcium channel blockers. You would obtain a TEE, which is not on this diagram, to assess for whether or not there is a clot that's at risk of embolization within the atria. You assess the duration of the arrhythmia, less than 48 hours. In the absence of the TEE, you can assume that there's not a clot. And this gets a little tricky because you don't know how long somebody has asymptomatically had atrial fibrillation, or you might have a spurious history and they say, well, I felt some palpitations a couple weeks ago, but I'm not really sure what that was. So if it's less than 48 hours and you have a strong history of it, maybe it was provoked, you can go ahead and do early cardioversion, either with current or pharmacologic. If it's greater than 48 hours, then you need to do anticoagulation therapy and get rate control. After 3 weeks of anticoagulation, then you attempt cardioversion, and then you anticoagulate for 4 weeks afterwards due to a little bit of a stunning period where you're still at an increased rate of an embolus. So how do you treat the patient who comes in with acute AFib with RVR? If they're hemodynamically crashing, unstable like we talked about, you would do electrical cardioversion, you would shock them. You wouldn't care about the embolus because the pulse pressure matters more. You would give fluids now if you're at risk of, well, do they have heart failure? Are we going to overload them? And you would diurese later. Pressure is more important than fluid on the lungs. We can always take up your oxygen. You can always intubate someone if you need to, but you have to keep the pressure up. So even if you have to give fluids, you can still diurese later. But if they're stable enough to try pharmacologic therapy, do so first. These are some of the rate control drips as well, metoprolol, which you'll see more commonly, propranolol and diltiazem, as well as with the initiation and onboarding, which we're not going to get into. And then you can do rhythm control with either digoxin, amiodarone, sildenafil, or a whole bunch of others. At this point, you're definitely consulting cardiology. They've probably already been on board, and you should have had somebody call them the second you realized that they were in an unstable situation with A-fib. Other considerations for the patient with atrial fibrillation, these are in the inpatient setting as well as in the outpatient setting. Anticoagulation with either warfarin, rivaroxaban, or apixaban. Antiplatelet therapy does not cut it. You can modify risk factors, which will reduce the frequency of AFib for a patient, or maybe even convert them back into sinus rhythm. That's increasing weight loss, obtaining good blood pressure control, treating obstructive sleep apnea, which reduces some of the pulmonary complications, as well as being helpful for blood pressure, and then helping someone control their diabetes and get their lipid profiles under control. Further studies that you consider about would be getting an EKG to verify the diagnosis if you haven't already done so, obtaining a TTE or a TEE to assess for the presence of a thrombus before cardioversion, or evaluating cardiac structure and function, which may be independent causes of the atrial fibrillation, obtaining stress test monitoring to assess for possible CAD in the setting as well. And then if you still don't know for sure if you have the diagnosis, you can do ambulatory monitoring with something like a Holter to try and catch paroxysmal AFib when the patient's outside of the clinic. So some of the parting questions, this is our key takeaways for today. So if somebody comes in, you think they might have AFib, you got to ask, do they have it? Do a physical exam, assess the heart rate, obtain an EKG. Then you ask, are they stable? If they're not stable, cardiovert, fluids, and rate control. And then you ask, well, where do I start? And so in the treatment of it, it's about the time duration. Remember that 48-hour rule. And then determining if you're going to start with rate control, which you can do in the primary care office, or if you're going to move on towards rhythm control, maybe later in the primary care office, or ablation, cardioversion, which would definitely be involving your cardiology colleagues. That's all we got for today. Thank you very much. Here are my references. If you have any questions, leave them on the comments below or shoot us an email at info@decodingdx.com. Thanks so much. Have a good day.